So I've got to persuade you that LabOICS are more effective in COPD than dual combination. And I start off from a winning point, is there's actually much more evidence on LabOICS than there is obviously on the dual bronchodilation, because we've had LabOICS combinations for a very long time. Those are my presenter disclosures. So we start off with the premise, of course, that COPD is an inflammatory disorder. And I think this paper was one of our key papers from Jim Hogg in respiratory medicine and in COPD. And in addition to showing us that, how inflamed the airways are, the other important figure, which I haven't brought today from the paper, in fact shows that over time, inflammation in COPD airways gets worse. So in stage 4, FEV1, less than 30% predicted, airway inflammatory changes progress. So this is not a condition that burns out. We see progressive neutrophilic inflammation, particularly over time. The other point about COPD, as you know, is that we get systemic inflammation. And this is an interesting combination of 3 papers. And I was sitting one Saturday at home when I was editor of Thorax. And would you believe it? These 3 papers came in the same morning. And I have a rule about not liking papers on the same subject, but they were all slightly different, showing the importance of systemic inflammation on COPD. And Don Sin, in fact, combined them and showed that as FEV1 gets worse, the CRP increases. So again, we get progressive systemic inflammation. I take the point, we still don't know exactly what the systemic inflammation is doing. It's a key feature of COPD. So if we talk about LabOICS combinations, we are looking mainly at exacerbation prevention. And this is, I think, the way we manage COPD now. Best current control, and we use oral steroids to treat acute exacerbations. There is evidence based on that. But exacerbations are key to future risk reduction. And in fact, at the moment, we don't have any treatments that affect disease progression. And as you can well imagine, I'm going to focus quite a bit today on exacerbations. So this slide really tells you why we need anti-inflammatories to prevent exacerbations. As you know, a virus causes more airway inflammation. I'm going to show you some data later on that and susceptibility, and the airway has more airway inflammatory changes. This leads to dynamic hyperinflation and symptoms. Now, the advantage of an anti-inflammatory to prevent exacerbations is that you can also impact the bottom left-hand side of this, potentially. And there are studies ongoing. There's a Summit trial that is actually trying to show if by treating airway inflammation and thus preventing exacerbations, actually you can affect cardiovascular comorbidity. So there is an innate advantage of getting to the crux of the process. Exacerbations are important. I'd just like to show you some new data from our group, and this was our interest, Anand Patel, one of our fellows in airway, in arterial wall stiffness. I'm not totally sure of the significance of this, but what you can see in red is arterial stiffness increases, particularly where you get viral and or bacterial exacerbations. The blue ones are exacerbations without any evidence of infection. The other point I'd like to make on this is how long exacerbations last. You know, we're used to just counting these events, but I'm very keen on looking at the whole event, and I think studies need to particularly take this as an outcome in the future. So this is data from Neil Barnes, and he was one of my colleagues. He now has gone to work for some others. In fact, he's gone to work for the sponsors of this study. He was so enamored with this study that, he made the natural progression. And what you see here is, this is salmeterol fluticasone, a 3-month study. I remember it being done. And this was an excellent biopsy study. All the samples were read in Peter Jeffrey's department, who was an expert on this. And what this shows, after 3 months, there was reduction of CD8 lymphocytes in the airway after 3 months of a LABA-ICS combination. Now, this is important. There are other studies showing the same thing. The problem is biopsy studies are pretty difficult with interventional studies. So we can show an anti-inflammatory effect. The argument is that you can't show very much in sputum. Well, my experience with sputum is the same with macrolides. We could not see any effects in sputum on airway biomarkers. So this is the TORCH data, and again, this was subject to a lot of controversy at the time, but actually it shows a pretty respectable reduction in mortality. And in fact, not many of our interventions have shown a reduction in mortality, and the LABA-ICS reduced by 17.5%. The problem was this missed statistical significance due to an interim analysis being performed. And this is the problem. The more you open up data, the greater the standard has to be for significance in a clinical trial. So the other thing about the LABA-ICS combination is this, and this is shown much less. This is the quality of life data from TORCH, and what you can see, that's placebo. So you get a little improvement. So negative is a reduction, you get an improvement, and then over 3 years the patient got worse. If it's positive, the patient gets worse. So this is the placebo, and then if you see salmeterol, so the LABA on its own, the patients still end up worse after 3 years. That's the fluticasone. But what I think is important, the LABA-ICS combination, in fact, after 3 years, the patient is still better than when they started off. So I think this is quite compelling evidence of the importance of the LABA-ICS, and in fact the way these lines separated. SGRQ is closely related to exacerbations, and this is the exacerbation data from TORCH. And as you can see, there's a 25% reduction on the LABA-ICS compared to the placebo. Now, this is important. We will not be seeing placebo-controlled studies anymore. So it's lovely to see the 25% reduction, but I think this is something generally of the past. I'll show you with one exception. If you compare with salmeterol, you're talking at about 12 to 14% reduction of the LABA-ICS against the LABA. Now, I think this is the exception. So I think the next issue about LABA-ICS is that we've been probably using too high doses. And I remember when Isolda, which was ICS against placebo, was developed. I was then on the steering committee. And the view was that we needed high doses of inhaled corticosteroids or even oral corticosteroids to get over the oxidative stress and steroid resistance. So in fact, nobody ever did lower dose studies of ICS. And this is, in fact, one from the States. This is one from Ferguson, and there's a very similar one from Tony Anzueto. So this is fluticasone salmeterol in a lower dose, 250 over 50, against salmeterol 50 on COPD exacerbations. And what you can see is the magnitude of the effects. In fact, these are some of the biggest effects that have been seen, about a 30% reduction, moderate to severe, and this is corticosteroid treated by 40%. In fact, the sister two identical studies were done for registration purposes, and the identical study, I could show you, has almost identical data. So I think the message is that LABA-ICS combinations reduce exacerbations, but you don't need the high dosages that we've been used. You can use a lower dose, so this is 250, 500 mcg daily of inhaled fluticasone. However, we now know that COPD is changing. And I know in the UK, the number of stage 4, less than 30% FEV1 patients is getting less because we can monitor that with oxygen prescriptions. We know the number of patients needing home oxygen is actually reducing in the UK, probably over the last 2 or 3 years, by about 30%. And this is because most of COPD, 60% of COPD, is in the stage 2 category. And you can see that in green in women and in purple on the right-hand side in men. And you can see there the stage 3. There's a lot of variability around the world. We know that. This is from the BOLD data. but 60 to 70% of COPD is in the stage 2 category. And I'd put it to you, as we get better and better at detecting early COPD, this will become even greater. So how do these treatments work in GOLD 2? Most of the studies on LabORE-ICS have been done with an FEV1 below 50% predicted. And this is the post hoc analysis that was published by Christine Jenkins. On the left, you get less than 30% predicted. On the right is the result in patients with an FEV1 more than 50% predicted. This is exacerbation rates. In fact, if you look at the percentage change, it is greater in the GOLD 2 patients than it is in the GOLD 4 patients. In fact, by the time you get to GOLD 4, in fact, you get remodeling, you get respiratory failure, pulmonary hypertension, and actually what drives exacerbations and hospital admissions becomes pretty complicated. So I'd put it to you that we can use LabORE-ICS in patients with GOLD 2, that's FEV1 50 to 80% predicted, with an exacerbation history. Of course, the greater the exacerbation history, the greater always will be the effect on exacerbations. And I will come back to that comment in a moment. This is a more recent data. This is last year, about a year ago, from Lancet Respiratory. And this is the data by Mark Dransfield on the new LabORE-ICS. So this is vilanterol and fluticasone furoate. Now, I'm showing you this slide for very specific reasons. And in fact, for very specific reason, and that is that you can see, I'll get a pointer here, you can see here the effect of dosage. And I don't think this works. And what you can see is the green line is vilanterol on its own. But what you see is the bottom two lines are two different doses of fluticasone. And for time to the next exacerbation, whether you were on the higher or the lower dose of fluticasone, it didn't make any difference. So this is why Relvar, which is fluticasone, and vilanterol has actually been marketed at the lower dose for COPD, certainly in the UK, and I assume in Europe also. So the new once-daily LabORE-ICS combinations also reduce exacerbations, but as in the Ferguson US data, you don't need to go to the highest doses. This is very important, of course, from side effects. So it adds to the safety of these preparations. So I'm now going to have a little bit of fun, and I really would like to take you back to this diagram, and as you know, the position of ICS LabORE is in C and D. The problem I have is about the 2 exacerbations per day. None of the studies I have shown you to date have been done in the frequent exacerbator phenotype as defined by GOLD, which is 2 or more exacerbations per year. In fact, there's a study going on with roflumilast at the moment, but these are very difficult patients to recruit. And in fact, most of these studies have had exacerbation rates around 1 or even slightly under 1. So I'll put it to you that we really cannot wait for 2 exacerbations per year or 2 hospital admissions per year till we decide to do anything. The GOLD has changed that into one exacerbation rate. And in fact, this I think is the evidence, and this is data from Alvar Augusti. And what Alvar showed in this paper, that increased comorbidity and systemic inflammation. If you look at GOLD B, and you remember that GOLD B are the ones on the right-hand corner, so they're the symptomatic patients who have only 1 exacerbation per year or no exacerbations per year, that these patients behave very similarly to patients in Group D. And I think, to me, this is the problem with GOLD, that B and D probably have very similar risk. And if you look at risk, D is always a bit worse because patients have more severe FEV1. But these Group B patients at high levels of systemic inflammation and they get exacerbations, they may also not report exacerbations. This is another slide from Eclipse that you may have not seen before in this format. You usually see only 2 exacerbations shown versus no exacerbations. But what you see here is the red is hospitalization, the orange are the patients who've had 2 exacerbations in year 1, but the yellow is the important bar. These are the patients who've had 1 exacerbation in the previous year. Now remember, any of you who did ECLIPSE, they were fairly stable patients in hospital and very, very well followed. And virtually all of them were on a LABA-ICS and a LAMA combination. So these patients were optimally treated. Despite that, you can see what the exacerbation burden is in these patients. And if patients are not treated, the exacerbation burden is greater. And this is why that there's a large number of exacerbations that are not reported. And we've known that, anybody who's done diary cards, and now with studies with the Exact Pro, we're seeing it all the time. So if you have 1 exacerbation that's treated, you will get at least another one, if not more, that is untreated. And our group and others have shown that these unreported exacerbations also affect quality of life. So really, exacerbation frequency to me is a little bit like Macbeth. So this is Macbeth, this is Banquo to the witches. If you could look into the seeds of time and say which grain will grow and which will not, speak then to me. And I put it to you, if you can predict the exacerbation frequency of a patient, you'll do well. The problem is people change. And we've done another follow-up paper to ECLIPSE showing that around half the patients over the 3 years will wobble their exacerbation frequency. So if we now look at the famous ECLIPSE diagram, and I haven't got the pointer here, but I'd like you to look, I don't think this works, I'd like you to look at the white bar in the middle. Those are patients with 1 exacerbation in the first year. You can see, as they go on over 3 years, that anything can happen. So remember, these were treated patients, stable patients, but they reported exacerbations generally to hospitals, and I would put it to you, they probably had more events. So the frequent exacerb phenotype is important, and it's a vicious circle. So patients are stable, they have higher susceptibility to bacteria and viruses, and this causes a vicious circle. And what you can see here is all the end result, all the effects. Sorry, thank you. Thank you very much. Lovely. Yeah. This is, in fact, my new diary. Oops, I put it here. Is that right? How do you? Where do you put it in? Sorry.
Yeah.
Oh, in.
You can't see it, but it's working.
Oh, it's working, yes. This is my new diagram. If anybody has any suggestions to improve it, greatly appreciated. So we wanted to give the idea of a vicious circle. And these are all the effects: FEV1 decline, poor quality of life, worse comorbidity. These are all the things that the frequent exacerbator is actually prone to. But at which level of exacerbation frequency this vicious circle starts, I, like Banquo in Macbeth, find it very difficult to tell you. I'd like to show you some data which is just accepted in the ERJ, and Mark told me he's doing an editorial, thank you very much. And this is, I think, the first time that we've shown that there is increased susceptibility to human rhinovirus at exacerbation. So this is exacerbation frequency. Patients who were virus positive were more likely to have a higher exacerbation frequency. If you notice, we haven't put a cutoff on. I don't like cutoffs. So this is a gradual scale. The exacerbation frequency is higher in patients who have more virus at exacerbation. But this, to me, is the important graph. On the left is rhinoviral load, human rhinovirus, the common cold by PCR. What you see here, that at exacerbation, the greater the number of exacerbations you have per year, the greater is the viral load at exacerbation, which means these people are more susceptible. And we need to tackle it. We know in asthma we can reduce rhinovirus-induced exacerbations, and this is why we need an anti-inflammatory agent to treat. So just to finish off, other issues with LABA-ICS, we know the more exacerbations you have, again, no cutoff, the greater the chance of having a myocardial infarction. And Torch also showed that the LABA-ICS, so this is serotype at the bottom, had a lower rate of cardiovascular adverse events. So there may be a protective effect of LABA-ICS on the heart in people with COPD. And in fact, that's being tested at the moment in a summit trial. So INSPIRE was the first time there was a direct comparison of a LABA-ICS against a LAMA. And this was the data. There was no difference in the rate of all exacerbations, but when you broke it down, exacerbations requiring steroids were reduced on LABA-ICS. This suggests that we were reducing the severity of the exacerbations. My recovery, severity and recovery go together. While exacerbations requiring antibiotics were less on tiotropium, presumably because there is less sputum around. This, in fact, shows you that patients on LABA-ICS had a much better, if you go down, that's better quality of life over the 3-year period, and this was pretty consistent, again suggesting that we were reducing the severity of the events. Withdrawal, again, was much lower. Withdrawal is or has been linked to outcome. Nothing much happens, of course, for the first year, but then you can see a reduced withdrawal of patients on the salmeterol fluticasone. So what other data do we have on LABA-ICS? Well, sadly, we have very little data on combinations of LABA-ICS plus LAMA. This is one of the studies that was done by Sean Aaron, and this was a study to evaluate the triple. Unfortunately, it was underpowered. The exacerbation data was non-conclusive. But here you see some more data on health status. Down is improvement. The triple did better than the TO plus salmeterol and better than TO plus placebo. So this is further evidence for improvement. So what about the comparison of LABA-ICS versus QVA and LABA-LAMA? And I'm sure you'll hear more about this from Nick in his contribution. But this is, in fact, SGRQ. These were patients all in group A and B. These were mild patients, and there was no difference in SGRQ. The only thing I'll give to Nick at this stage is that SGRQ performs much better in more severe patients. What about safety? And this is data from Torch on lumbar spine bone mineral density, and you can see over 3 years there was actually no difference, no worsening of bone mineral density. But the issue is, of course, over pneumonia. And I'm going to show you some data on why I think there is an issue with pneumonia. And this is the INSPIRE data, time to first pneumonia. Patients on the LABA-ICS had a faster time to the first pneumonia, and we now accept that there is a small but significant effect. And the effect is actually small. This is now data from the Ferguson study on the lower dose. And here you still see 7% versus 4%. You see a small pneumonia signal. But relative to the reduction in exacerbations, this is small. So INSPIRE had over 2,500 exacerbations. It had 100 pneumonia events. And I'm actually going to show you some diaries from INSPIRE. Now, these are in an appendix, and probably nobody ever looks at them. But what we did is we asked patients to complete a diary based on the London COPD cohort. Breathlessness, sputum volume, they did it every day. This is the point 0 on all the curves when pneumonia started. And this was a classical pneumonia. Patient actually suddenly needed antibiotics, and a diagnosis at that point was made of pneumonia. We call that a classical pneumonia, because if you remember, x-rays were quite sparse on all the patients. This is, in fact, a different type of diary. So the patient's breathless, has a cough, has a cold. The patient had an HCU exacerbation, which means they were treated with an antibiotic. After about 2 weeks of treatment, suddenly that gets called a pneumonia. And some of these pneumonias we looked at, it was pretty clear these were exacerbations that had gone on, and patients hadn't got better. We know exacerbations can last forever. And this is what happens. This is another one. This is, in fact, an untreated exacerbation. So a patient has a lot of sputum, has a lot of cough, nothing happens. They have a symptom exacerbation, no treatment. At that point, this gets called a pneumonia. There's a lot of confusion between exacerbations and pneumonia, but I think one way to reduce the pneumonia signal is early intervention. This is a very good example of somebody who should have been treated at this point, not at this point. We see very little pneumonia in the cohort, and we believe it is because of the early awakening and early reporting of the patients. So some of you may know I'm in 3 weeks' time moving from UCL to take up a newly created chair for me at the Brompton and Imperial, and I'm really, really very pleased about it. I'll have a new email. I'll send it to all of you. But I'd just like to come back to this book, which was written by a Brompton consultant. In fact, I found the original version was found when we were still in East London at the London Chest. And what is quoted, there's a fantastic description of COPD exacerbations in this book. But the advice is, next to avoiding a fatal issue, our efforts must be directed to prevent the case going on to chronic bronchitis. And chronic bronchitis was really progressive COPD, especially in those who've had previous attacks. So I'd like to put it to you that we need LABOR-ICS to prevent exacerbations and that they are effective in COPD patients. Thank you very much indeed.